Not unmuted.
Okay, good afternoon, everyone. Looks like we were unmuted at first and you did not listen to the introduction. So I welcome all of you to our session for the day. Today we are going to be talking about the package of care for advanced HIV disease, which will be a very important topic and very interesting. It shall be shared by Dr. Mupeta, who will give the didactic lecture for the day. And before we can get into the details for the agenda, we shall quickly go into updates for the COVID-19, which will be given on a weekly basis. So Dr. Mupeta, over to you.
Thank you very much, Dr. As of this morning, which is 2nd March 2020, the number of confirmed cases are 8,107. And then suspected cases are 715. The number of deaths recorded worldwide is about 2,915. And those who have recovered are in the majority, they are 44,518. The number of deaths that have been recorded outside China, notably, is Iran, which is at 43. And then the US is said to have recorded its first death this morning. Then good news coming from Wuhan there is that the makeshift hospital closed yesterday after the discharge of the last patient they had. So this is a very good news because it shows that the number of cases are down. Then I know that a number of people have been asking about treatment guidelines. We should be patient. As of this morning, there are no validated treatment drugs that have been approved for COVID-19. However, it should be noted that a number of them are being tested in clinical trials. Interim guidelines for Zambia definitely will be ready this week, and then we are expected that we speak the same language. So that's.
Thank you very much. So getting into the agenda for today, I'll quickly give a recap of last week's discussion, which was on ART in children. We talked about dolutegravir use in children, and of course it was mentioned that dolutegravir can be given in children who are above the weight of 20 kg. We further talked about indications of TAF in children as well, and we made mention that TAF can also be used in children who are above the weight of 25 kg. And of course, dolutegravir, tenofovir disoproxil fumarate, which is the TDF, can also be used in children who are above the weight of 30 kg. We discussed briefly on the indications of ART in TB, the combinations, and we also learned that TAF cannot be given with the rifamycin, such as rifampicin, and so it should be avoided, and other alternatives can be given. We also had the new dosing charts for children, and we cannot go into the details of that, but those are charts that we can all get familiar with in our practice. And it's also important to note or remind ourselves that in children, ART should be given on a weight basis. There was a poll question which talked about the side effects of dolutegravir. The side effects of dolutegravir. Okay, do we remember this question which was shared last week? Just sorting out a few technical issues. Okay, so we had this poll question number 2 last week. which reads, all the following are side effects of dolutegravir except there was headache, hyperglycemia, rash, suicidal thoughts, and birth defects. There was an issue with this particular question, but we just want to clarify that actually all those are side effects of dolutegravir, and the issue was on hyperglycemia not being a side effect. But let us just remind each other that hyperglycemia is also a non-side effect of dolutegravir, as dolutegravir increases insulin resistance, which can lead to hyperglycemia and also weight gain. So these are some of the things that we need to be wary about as we attend to our patients. So at this point, we shall now go into the didactic lecture, which will be given by Dr. Mupeta.
All right, good afternoon, everyone. So today we'll be talking about the package of care for advanced HIV, and specifically focusing on screening for the big, core diseases. This is basically cryptococcus, TB, PCV, and then cervical cancer. This is basically what will be our focus. So the objectives for today is to describe the overview of screening for infections in advanced HIV. And then we also look at considerations in pediatrics, what is happening, and not just. And then we describe the screening tools which are used for preventive strategies. So I'll take you back to Dr. Zico for the focus.
Okay, so the poll question number 1 is a true or false question, which reads, all patients with a positive CrAg should be preemptively treated with fluconazole. So let us all participate. We only have 2 options. It's either true or false. So we have 30 seconds to answer the question.
Yeah, you can also participate. Sorry? People agreeing or disagree?
Okay, so we have 65 who have participated. We'll end the poll now. Okay, so the next question, which is poll number 2, is urine lump can be used in which of the following patient groups? So we have A, CD4 less than 100 cells, RR more than 30, unable to submit sputum due to being seriously ill, unable to walk, or all of the above. 30 seconds to answer the question. What's our response in the hub? All of the above. All right, we'll end the poll. Poll number 3, about PCP prophylaxis in children. Which of the following is true? Start cotrimoxazole prophylaxis when CD4 less than 25 in children older than 2 years. Cotrimoxazole prophylaxis is indicated in WHO stage 2 to 4. HIV-exposed infants do not need cotrimoxazole prophylaxis. Then B, HIV-exposed and infected children should receive cotrimoxazole prophylaxis from the age of 6 weeks. What's our answer here? D. Okay, we shall end the poll and go to the next one. So the last one, which of the following statements is true? Cervical cancer is AIDS-defining cancer. Cervical cancer is associated with HHV8 infection. Cervical cancer is associated with HPV infection. Cervical cancer cannot be prevented in advanced HIV disease. Our answer is C. Okay, we shall end the poll now, and over to you, Dr. Mupeta.
So thank you very much. So why is it important to talk about screening for opportunistic infections in advanced HIV? The reason is because opportunistic infections are the commonest cause of morbidity and mortality. And we know that some of the big opportunistic infections in HIV includes cryptococcal infections, TB, PCP, and STIs. So we know that we've got a three-pronged prevention of death strategy, which involves about 3 parts. Number 1 is early diagnosis and CD4 count. And this is basically where we are talking about that you make a diagnosis early and then you do the CD4 count as well. Second one is early insertion of ART, and we know that we are in the test and treat era. And the third part, which is important, is screening for opportunistic infections, which includes the 4 that we are talking about. All right, so let's look at why are we screening for cryptococcal infection. So cryptococcal meningitis is a serious opportunistic infection, which is the major cause of morbidity and mortality in people with advanced HIV. It accounts for about 15% of all AIDS-related deaths globally, and about 2/3 are actually in sub-Saharan Africa. And Zambia contributes to that statistic, being the 10th highest in the world. So we can imagine that out of all the 100 and something countries in the world, Zambia is number 10 in terms of the highest mortalities from. So therefore, screening with cryptococcal antigen prevents invasive cryptococcal infection. Who should be screened? So what we are saying is that all HIV and AIDS patients should be screened for cryptococcal. And then all patients starting ART as well, and all HIV and AIDS patients with advanced disease who are defined as CD4 less than 200 cells per mil. Okay, so what we know is that when a person has got cryptococcal infection, so we actually find that the antigen will be detectable in blood, right? We know that the cryptococcal transmission is via inhalation through the lungs, and then you get bacteremia, or sorry, you get the antigen in the blood, and then dissemination, which involves patients. Now, when a patient is infected, the first to appear the antigen in blood, they will basically be asymptomatic. Then they'll eventually progress to developing cryptococcal meningitis, which is infection of the brain meninges. And the lead time is actually an average of 3 weeks, but it can be arranged from anything from 5 days to 234 days. So you can see that this will depend on the type of person and, of course, the level of immunity. Now, it's at this point that we screen for cryptococcal infection so that we can stop and prevent progression. So what we do is that we actually take just serum and tests using a lateral flow test, antigen tests, which are readily available. Okay, so what are the recommendations for screening and preventing cryptococcal? Persons living with HIV with a CD4 less than 200, or anyone in clinical stage 3 and 4, or those with danger signs, which I'm going to talk about, should actually be screened with cryptococcal antigen, serum cryptococcal antigen. And then we should administer a lumbar puncture and conduct CSF antigen cryptococcal antigen test in all CrAg positive patients with symptoms of meningitis. So we have to consider an LP even when a patient has got no symptoms, especially if they have advanced HIV disease. Now, we preemptively treat all CrAg positive patients without cryptococcal meningitis. These are HIV patients who have advanced disease, not just anyone. And then we treat for cryptococcal meningitis in all patients who are diagnosed with cryptococcal meningitis. So the diagnosis, the cryptococcal meningitis will be diagnosed if the CSF CrAg is positive. And if the serum CrAg is positive in the absence of CSF testing, it should be added discreetly, especially in a place, or if you are unable to conduct a lumbar puncture for CF studies, then you can treat as you have observed clinically. Okay, so the treatment regime which are given in our guidelines is preemptive treatment regime will involve induction and consolidation with fluconazole 800 milligrams for 8 weeks, and then maintenance with 200 milligrams per day for at least a year, or until there is evidence of immune reconstitution in a patient who has been injected on PAT. ART. So in patients who have cryptococcal infection or meningitis, there is normally cryptococcal-related immune reconstitution, which is relatively common and quite life-threatening if you initiate ART early after the diagnosis of infection. So what we recommend is ART should be delayed for about 4 to 6 weeks from the initiation of cryptococcal treatment, including when we initiate preventive measures. So for patients who are being preemptively treated, these are patients who don't have cryptococcal meningitis but have got positive serum cryptococcal antigen. For them, the recommended lag time is actually 2 weeks. We delay ART for 2 weeks if you are preemptively treated. If you are treating cryptococcal meningitis, then you delay for 4 to 6. This is important that we understand these types of delay. So the 2 weeks is for those who are being treated preemptively, and then 4 to 6 weeks for those who actually are being treated for cryptococcal meningitis. For patients who are already on ART at the time of diagnosis of cryptococcal meningitis, we should not stop ART or temporarily or for whatever reason. ART should be continued and alongside the treatment for meningitis. All right, so this is an algorithm that has been developed just to help us understand what we are talking about. So if you have got a patient with advanced HIV or stage 3 or 4 disease or initiating ART, what we need to do, the first thing we need to do is screen with a serum CrAg. If it's negative, immediately inject CrAg. And then if it is positive, then you actually screen now for symptoms. And the symptoms you screen for are any presence of headache, any changes in mental status, confusion, seizures, or any CNS symptoms, presence of neck stiffness. If these symptoms are absent, you actually proceed to treat preemptively with fluconazole 800 milligrams for 2 weeks. And then at the end of the 2 weeks, actually, you continue fluconazole 800 milligrams. Sorry, after 2 weeks, you continue fluconazole for 200 milligrams, and then you initiate ART. The 200 milligrams should continue for at least a year until the patient is suppressed after being on ART, or immune reconstitution, which is the CD4 goes above 200, and ensure that this treatment is at least for a year. On the other arm, if the person actually tests positive for any of the symptoms for cryptococcal meningitis, you have to proceed to do a lumbar puncture. If the lumbar puncture is negative on CSF CrAg, then you proceed to treat preemptively as we suggested. If the lumbar puncture shows that there is presence of CNS disease, and CNS disease could be present when the CSF CrAg is positive, then you proceed to treat for cryptococcal meningitis as per guidelines. Okay, so the next one is screening using the urine lipoarabinomannan test, which is the screening for presence. So detection of LAM in urine is indicative of disseminated TB. So the indication for urine LAM is for people living with HIV. One, they should have advanced HIV. And this advanced HIV, we mean anyone with CD4 less than 100. So this has been shown to actually be highly sensitive for advanced HIV with CD4 less than 100. If the CD4 is above 100, the sensitivity actually goes lower than what it is. Then the other patients where the LAM is very useful, any person living with HIV was a serious illness, when CD4 count is not available, then you can base it on one who has got a serious illness. And serious illness we mean one who is in admission and having respiratory rate above 30 breaths per minute, and then a heart rate of more than 120 beats per minute, or anyone who is moribund, unable to walk and cannot walk and that's in bed, then it means that the urine LAM will be actually used. I'm not going to talk about the use of the gene expert and IPT, as this will be covered in later sessions. All right, so the third one is cotrimoxazole preventive therapy. So we know that cotrimoxazole prevents PCP, which is pneumocystic pulmonary pneumonia, toxoplasmosis, malaria, and cytosporias. Cotrimoxazole preventive therapy prolongs survival in HIV-infected individuals. This has actually been done in a number of clinical trials, including those that were done in the early 2000s here in Zambia and late 90s. HIV-infected pregnant women have got an advantage if they are receiving cotrimoxazole prophylaxis. It means that they are also being covered for prophylaxis for malaria, and therefore they should not be given Fansidar, which is normally given. criteria for initiating discontinuing of cotrimoxazole prophylaxis in children, if we remember that in the previous guidelines, the 2018, we had actually several categories for children. We're talking about HIV exposed infant, HIV infected patients below the age of 24 and those above. And there were different kind of criteria of when to start and when to stop. So this, fortunately, actually should be discarded as we have now a new guideline. And the indications for cotrimoxazole prophylaxis is now much simpler. So we are saying that start prophylaxis in children, in all children born to HIV positive mothers, starting from the age of 6 weeks. So we give this lag period because of developing bone marrow, which can be affected by septic. All children with confirmed HIV disease should also be started on septic prophylaxis, and all children below the age of 5, regardless of the CD4 or the clinical stage of disease. What we are saying in the 2020 guideline is that any child with HIV who is below the age of 5 is actually considered to have advanced HIV. For children who are above the age of 5, will follow the adult guideline. So adult guidelines, we are talking about all adults with advanced HIV. The standard dosing for children is actually 25 to 30 milligrams of cotrimoxazole per kg, or 4 to 5 milligrams per kg of the trimethoprim. And then it should be given once daily. The maximum is actually 960 milligrams daily. So this is the chart that is actually showing the dosing schedule for children, and I think this will be circulated. You can actually, based on the weight and what you're supposed to do. All right, when do we stop? HIV-exposed children, once documented HIV negative, and at least 3 months after the cessation of breastfeeding, then it will be no longer required to cover them for prophylaxis. HIV positive children, once they start, it should not be discontinued regardless of the clinical or immunological status until after the age of 5, when they will enter into the adult category. Then HIV positive children above the age of 5, we may consider stopping if the CD4 was above 350 cells per mil on 2 occasions, and which are 6 months apart, provided they are asymptomatic and they are on ARVs. Adults will talk about different categories. We'll look at women, pregnant women. So for pregnant women, we start cotrimoxazole prophylaxis as soon as possible. And we are also being reminded that for pregnant women, once you start on septic prophylaxis, please do not give Fancida for malaria prophylaxis. Then you start, and when we stop, this should actually be continued throughout pregnancy. Not stop septic prophylaxis at any point in a pregnancy. For breastfeeding women, we continue the septic prophylaxis if the CD4 remains to be less than 350 mils, or if they are in WHO clinical stage 2. And then when you stop for breastfeeding women, you consider stopping septic prophylaxis if the CD4 cells are above 350 cells per mil, or on 2 occasions, while on 6 months apart and while on continuous antiretroviral therapy. Adolescents and adults, it's the same, and children above the age of 5. So we start septic prophylaxis if the CD4 is less than 350. In the absence of CD4 testing, you can actually use the WHO clinical staging, stage 2. The only time that septic would not be indicated is if one has got a CD4 above 350, or WHO clinical stage 1. You stop if the patient actually moves CD4 above 350 mils on 2 occasions which are 6 months apart, and provided this patient has been on ARF. Okay, so the next one we'll talk about is cervical cancer. Cervical cancer actually continues to be one of the cancers which are very common in Zambia. And we've seen that Zambia actually stands third in the whole world after Swaziland and Malawi in terms of the highest prevalence, and we stand at 6.4 per 100,000. So that's quite high, and we are number 3 worldwide. Now, cervical cancer actually can be prevented using HPV prevention, and we look at vaccination. Screening for cervical cancer should be the same both in vaccinated women as well as in unvaccinated. HPV vaccination currently is being offered in Zambia universally, and we are using a gut seal HPV vaccine, which is a quadrivalent vaccine, meaning that it contains or it's able to cover for 4 serotypes. And we are recommending that it's given at the age of 15 and then repeated at the age of 15 to maximize the protective effect of vaccination. So HPV vaccination is not protective against all oncogenic viruses other than type 16 and 18, which normally accounts for about 30% of the cancer-causing viruses or serotypes of HPV. Cross protection for non-16 and 18 can only be partial, and this is actually doubtful in 19%. Meaning that even after the vaccination, it does not mean that you cannot have cervical cancer, as the non-dominant serotypes can still cause cervical. Now, the other reason why one can develop cervical cancer even after vaccination is that you may have a poor immune response, all right? So meaning that even after you've been vaccinated, you cannot get the full immunoprotection. And this normally is seen in the immunocompromised patient or in those that receive a partial dosage. So meaning that instead of getting the 2 recommended vaccines, you get only 1. So that may not actually give you full immune protection. Then the duration of protection of HPV vaccine again remains unknown. If you are vaccinated, you get a full immune response and protection. We don't know how long that immunity is going to last. Whether we need to repeat after 10 years, after 20 years, still remains to be answered. That can also not prevent somebody to develop a form of. So basically, we are talking about prevention of cervical cancer, which can be primary prevention and secondary prevention. So primary prevention basically is avoidance or reduction in risk sexual behavior, and then use of condoms and HPV vaccine. And then secondary prevention is basically screening for cervical cancer and then treatment of any suspicious cancerous lesions that may be found. So these are basically some of the conventional screening tests that are there for cervical cancer. So we have got number 1, a pap smear, all right? Number 2, we've got PIA, which is visual inspection with acetic acid, and then we've got HPV DNA tests, and then a rapid DNA test. All this can actually be used to screen for cervical cancer. What do we then do when we screen these women for cervical cancer? So if we actually use the VIA and it's negative, so we advise these women to be followed up for a repeat after about 1 to 3 years. And then if VIA is positive and you determine that this woman is eligible for cryotherapy, please you provide on-site cryotherapy, and preferably the same visit, so that we don't lose these women. And once send them home, there's a high possibility that they might not come back. And the next time we see them, it would have blown into cervical cancer. And then if the VIH is positive and the patient is not eligible for therapy, you actually now provide a referral hospital that is able to do LEAP. And then after a LEAP is done, you advise these women to be followed up 1 to 3 years. So following up of women living with HIV, with positive VIH lesions, so any lesion that is greater than 75%, and those that are extending onto the os should actually be referred for LEAP. And then samples exercise should be sent for histopathology, and please, this should be emphasized to ensure that we send for histopathology characterization and whether it has gone into it's just carcinoma in situ. They should also be reviewed immediately for interpretation of results, as any delay can actually result in the progression of cancer. And then if the results are confirmed, they should be screened again in 6 months' time to check if the LEAP treatment was. Okay, so summary of what we have talked about today. We have talked about the prevention of death in HIV following about 3 prongs, and this is early diagnosis, test and treat, early insertion of CARs and screening for opportunistic infections. Then it's always important that we screen for cryptococcal meningitis and TB in all patients injecting CARs or with advanced HIV disease, defined as a CD4 less than 200 or WHO clinical study. All children under the age of 5 and adults with a CD4 less than 350 mils per mil, 350 cells per mil, should be on septin prophylaxis. For cervical cancer and HPV infection prevention, so primary prevention should actually involve risk sexual behavior reduction, use of condoms, and HPV vaccination, which is recommended for girls aged 14 and 15. And then secondary prevention of HPV infection, which involves cervical cancer screening and treatment of cancerous lesions. So these were the references, and we can go back to it.
Thank you very much, Dr. Mupeta, for that elaborate discussion. So we shall now go into the pause, and hopefully by now we shall be able to get the answers correct after that very nice presentation. So let's not disappoint Dr. Mupeta. Let's answer correctly. For question number 1 says, all patients with positive CrAg should be preemptively treated with fluconazole. Okay, can we answer that quickly? All patients with positive CrAg should be preemptively treated with fluconazole. What are we saying here? We are sure? Does anyone have a different answer? Okay, we'll go to the, before we go to the next one, Dr. Mupeta.
Do you want us to discuss now or we finish?
Okay, we can finish then.
Discuss now.
Okay, all right. So this is saying all patients with a positive CrAg should be preemptively treated with patients. We just walk in any hospital, any patient CrAg positive. All right. So what we are talking about is advanced HIV. So all people living with HIV with advanced disease, which is CD4 less than 100, with a positive CrAg, should be treated presumptively. Now, this one is not stating that this patient has advanced HIV, it's just saying patient. So we need to be particular about each patient. So the correct answer with this one is false.
So I think the other thing is that some of these patients may need full treatment for crypto, because some of them may have a positive CrAg. You do a lumbar puncture and they have cryptomeningitis. So those will need amphotericin B and fluco, so not the preemptive treatment.
Okay. Next 4.
Okay. For question number 2, urine lump can be used in which of the following patient groups? CD4 less than 100, respiratory rate more than 30, unable to submit sputum due to being seriously ill, unable to walk, for all of the above. That's our answer here. Okay, I'll end the poll now. Okay, we'll end the poll now and Dr. Mupeta can give us the answer.
Okay, well, thank you very much. I can see a number of responses. So urine lump, what we have to know about urine lump is, number one, it's indicated in patients with advanced HIV, and preferably if the CD4 is less than 100, meaning that the sensitivity is going to be high. Now, in the absence of CD4, which other HIV patients need or to be screened using RAM? Those who are seriously ill, and by serious illness we mean respiratory rate above 30, and those who have got a heart rate above 120, and those who are moribund, unable to stand on their own because of can't walk. All right? So we'll see that this question actually, options A to D are all correct. So it makes option E correct. All of the above are correct.
Okay, thank you very much. The third last, poll number 3, about PCP prophylaxis in children. Which of the following is true? A, start cotrimoxazole prophylaxis when CD4 less than 25 in children older than 2 years. B, cotrimoxazole prophylaxis is indicated in WHO clinical staging 2 to 4. C, HIV-exposed infants do not need cotrimoxazole prophylaxis. And D, all HIV-exposed and infected children should receive cotrimoxazole prophylaxis from the age of 6 weeks. Like we have a unanimous.
And are we starting? Something is not.
Okay, Dr. Mupeta.
Okay, so well, they are still voting. I can see a few who have gone for A and B. So remember what we said, that now all children under the age of 5 are considered to have advanced disease. So regardless of what the CD4 count is, as we used to do in the previous guidelines, or regardless of what WHO staging. In the 2018 guidelines, we were looking at WHO clinical staging 2 to 4. But what we are saying in 2020 is that any child less than the age of 5, regardless of the CD4 or regardless of the WHO clinical staging, is said to have advanced HIV. And all children with advanced HIV should actually be protected against PCP with septum. If we look at A, that one is talking about the CD4 falling below 25%. Definitely that's not true, because we are saying that you have to start before, regardless of the CD. If we look at B, it's also excluding those children in stage 1. We are saying that start septum prophylaxis regardless of WHO clinical staging in children under the age of 5. And then HIV-exposed infants do not need cotrimoxazole prophylaxis. This is not true. They will need prophylaxis, and we gave provisions on when to stop, only if they are documented HIV negative, and it should be at least 3 months after cessation of breastfeeding. It leaves us with D, meaning that all HIV-exposed and infected children should receive cotrimoxazole, and starting from the age of 6 weeks.
Thank you very much. The last one. So poll number 4, which of the following statements is true? Cervical cancer is AIDS-defining cancer. Cervical cancer is associated with HHV-8 infection. Cervical cancer is associated with HPV infection. And lastly, cervical cancer cannot be prevented in advanced HIV disease. Okay, we'll end the poll. And Dr. Mupeta, can you just clarify?
Okay, so thank you very much. So just to be quick on this one, cervical cancer is not AIDS-defining, and as even non-HIV women can also get about infection with HPV. HHV-8 causes Kaposi sarcoma, is associated with Kaposi sarcoma, and not cervical cancer. So that leaves us with the option C, right? Cervical cancer can also be prevented in advanced HIV. Even in women with advanced HIV, we have to follow the screening route so that we can prevent cervical cancer. So C is what is true. HPV, what is associated with cervical cancer.
Okay, thank you very much. At this point, we will not ask Dr. Mupeta any questions, but we'll go directly into the case presentation, which is from Yeta District Hospital. And the presenter is Brian Kawonga, the ART provider. Brian, are you there? Yeta District Hospital. Are we ready?
Hi, Zico. As Zeta is getting ready, I just want to make a clarification on the last poll question, that cervical cancer, whereas it's not, it is considered AIDS-defining when it is invasive in the presence of advanced HIV. So that's the problem with A. It's not invasive cervical.
Okay, thank you very much, Dr. Foloshi. Yeta, are we ready? Brian.
You can start going through the case.
Okay, so as we wait for Brian from Yeta, we'll start going through the case, and the history is as follows. We're talking about RM, a male 40, RVD since 29th May 2017, presented with history of collapsing and fitting 10 days ago at Yeta Hospital. He was seen a day earlier with complaints. He was seen a day earlier with complaints of headache, for which he received diclofenac and was sent home. He started on TLE in 2017, but transferred out of Mwandi after a year. He was reported to have missed, he reported not to have missed any clinical appointments from Mwandi. And in 2019 June, he developed progressive weight loss, fever, chronic cough, but not treated for TB. and there was no history of IPT either. In December 2019, his brother visited him and found that he had not been taking both Septrin and TLE. He was brought back to Sesheke. His social history is that he's a truck driver. He has a current wife, and the ex-wife, they are both RVD and on ART. Both children are non-reactive. His vitals were temperature 35. He was hypotensive. His weight was 55 kg, and that was in December. Then just about 2 months later, he reduced to about 43.7. His height was 1.81 meters, and his BMI was 13. General exam, he was chronically ill, wasted, pale, no jaundice, no lymphadenopathy, and oral cavity revealed oral thrush. On CNS exam, on the 17th of February, he was talking irrelevantly, he was irritable, resisting examination, unable to walk, and on the 21st of February, he was oriented to time, place, and person, and able to walk. So there was that drastic improvement in his neurological examination. Respiratory exam was clear. Heart sounds were tachycardic, and abdomen was scaphoid. LP was positive for cryptococcal formans on Indian ink. So that is a summary of his medications. In May, he was started on TLE, and he has been on that regimen up to now. His viral load in 2019 July was 1,752,098 copies, and he was started on enhanced adherence counseling in Mwandi. 3 sessions were done, and the client denied missing any doses, and he always kept his appointments. In February, on February 18th, viral load was pending, and so we do not have another result on the file. The CAT exam, serum CAT on February 19th was not done because there were no reagents. CSF Gene Expert was not done because the machine was not functional, but Indian ink reviewed cryptococcal neoformans, and he was commenced on fluconazole 1.2 grams once daily. The HB was 8.4, which then reduced within 2 months to 6.3. He was put on folic acid on both occasions. The chest X-ray was normal. The sputums were also normal. The CD4 was also reduced, 65 initially in October 2018, and about a year later, it was reduced to 16. And earlier this year, it was, can I say the machine did not detect any cells, but cotrimoxazole prophylaxis was given. Then the creatinine was estimated creatinine clearance was 52.1, and the genotyping for the HIV was pending. So this is a summary of his medications. And the questions that the YETA team are asking is, with a strong history of poor adherence to first-line ART, do we switch the client to second-line treatment? When would it be appropriate to make the switch, if so? And can we treat the client for TB additionally based on clinical presentation? Is Indian ink stain reliable in monitoring treatment? How often should it be done? Do we have the YETA team available now? Okay, looks like we do not have the YETA team, but those are the questions that we have from their end. I think at this point, if there is any question, Okay, Yeta team.
Good afternoon, Dr. Zico.
Good afternoon. Welcome.
Yeah, thank you. Sorry, we're having challenges here. We keep logging in and out. So,
Okay,
sorry for
so
that.
all right. So what we'll do now, we'll just get questions from the participants, and then you can answer before we can go into the breakout sessions. Is that okay? Okay. Do we have questions from the participants?
Pasha, do you want to summarize this case? Just a summary.
So we're presenting a male aged 40 who was initiated on treatment here in Sesheke in 2017 and later was referred to Mwandi, where he lived for a year alone. And he was brought back here in Sesheke in December of 2019 by his family members, who found that actually he was not taking the drugs at the time that he was in Mwandi for that year. There was a noted history of symptoms of TB from June 2019 to date. I think from the lab investigations that were shown, they were
We've lost her again. Okay, I think at this point we shall just request for questions from the spokes. Any questions before, any clarifications we need from them? Dr. Thomas?
This one defined why was he put on cotrimoxazole? When was the air distracted? What is the respiratory rate, the pulse rate? And was there any prior viral load before working?
Yeta, did you get those questions?
Sorry, can you get me?
Yes, we can get you. Did you get the questions?
Yes,
Okay, please attend to them.
please, we didn't get them.
Oh, Dr. Thomas, could you just?
We didn't get the question. Sorry, Dr. Zico, could you get them here?
Okay, just want to find out what is the respiratory rate, the pulse rate, then why was he put just on cotrimoxazole? And then when was he restarted on the ARV? And also any prior viral load. Because he was started on ARVs in 20s. First viral load is in 2019.
Did you get the question? Pasha? Pasha, did you get the question? Okay, due to lack of time, we shall just break into the breakout groups.
Which was about sorry, if you could just go back to the slides, but it was somewhere 1,000,000 copies, if I remember correctly. Yes, that's, yeah. Then
So before that viral load, did you have any other viral load?
No, we didn't have any other viral load done on the patient, except the one that we collected on the 18th of February, whose results were waiting.
Okay, we can hardly hear you. Can you just respond via the chat?
I think that's if I got the question correctly.
Okay, we can hardly hear you. We can hardly hear you. Can you just respond via the chat and then we can follow it from there? So at this point, we shall break into the breakout groups. We have in room 1, which is where myself and Dr. Mupeta are. This is room 1. Room 2 will have Dr. Ziambo and Dr. Chituo. And in room 3, we shall have Dr. Chengamwa and Dr. Sivile. So you shall receive the prompts on your screens and then you can join. After which we shall get back to the main session for the conclusion discussions.
Women's Day, mankala holiday. So per Monday, no holiday per Monday. Since we have a Sunday. Well, youth day. But we're saying a change. I said, what are the changes? And they didn't tell me.
We think moving this client to second line won't solve the problem. Yeah, because this patient has got issues that need to be sorted out. He has got weight loss, is severe malnourished with a BMI of 13. High viral load signal failure on that treatment. What he's taking? He's not taking medication, so there is that problem with adherence. He's having a chronic cough. So I think it could be better we screen this client for TB first to rule out if there's no TB that we are dealing with here that is untreated. Then from that point, if that is ruled out or is being taken care of, then we can move on.
Okay, thank you for that submission. So
explain that you can continue. Okay. Yes. Cinda, do you have anything to say about the case, the question that we're dealing with?
Yes, Dr. Zeko and Dr. Mupeta. Yeah, I think we feel like it's very important first to sort out the issues of poor adherence. Because if you just swiftly maybe switch to the second line, there's a possibility that the patient will still fail. So I think in addition to what Dr. Kavala was saying, I think it's very important to consider and to sort out the state issues of adherence.
Okay, so are we now proposing that we maintain the patient on the same regimen?
Yes.
What are we saying from the house here?
Yes.
Maintain the patient on the same regimen?
Yes.
Okay. Then sort out issues of adherence. But this patient underwent EAC, a number of sessions.
EAC was done. Okay. Yes, EAC was done, but we haven't seen the outcome. We haven't seen first the latest viral load. And then I also feel this person, from the history, it seems like this person stays alone. The brother went to visit, and then he found that he wasn't taking the ARVs. So I would also advise them to also involve the relatives, if possible, if they can. That person can stay with someone to monitor him that is taking the ARVs, other than the EAC that has been done. But with this EAC, you haven't seen the outcome after it was done after the 3 sessions. We haven't seen the latest viral load, and also changing the to second line, it will not work, even looking at the HB of 6.3. So there is also an issue of anemia. You know, the EAC was done in July, and then December he stopped taking drugs. So I don't know about the EAC. And then again he started the crypto treatment only on 20th February. So we just have to wait based on all those things.
Okay, I'll give Dr. Mupeta a chance to talk when we have discussed at the end. Can we treat the client for TB additionally based on the clinical presentation?
Are they able to do a lab there?
So the best would be?
It was possible to do a LAM also, because expert X-ray, everything is negative, just to see a LAM also. CD4 is.
Hello? Am I clear enough? Hello? Am I clear?
Chilenje?
Yes, this is Chisenga from Chilenje. So
Okay.
I think our clients were having adherence issues. If EAC was done, let them intensify it and make sure that the client is following the schedule for taking his drugs. And then even if you change to second line, adherence will still be a problem. Then also they need to investigate for TB. They just don't start the client on TB and do other investigation for that anemia. Thank you.
Okay, thank you very much. We'll go to the last question, and then Dr. Mupeta will sum it up. Is India ink stain reliable in monitoring treatment, and how often should it be done? Lewanika?
Can you kindly repeat the question?
So the last question is India ink stable stain reliable in monitoring treatment, and how often should it be done? Did you get the question?
Yes. For the India ink, it is not a very reliable test in monitoring treatment, because India ink may still be positive when the culture itself may be negative. So the best way to monitor is by doing a culture for the Cryptococcus meningitis, but fungus, instead of doing the stain itself.
Okay.
How often the India Inc is done, on that one, I'm not quite sure.
Okay, so due to lack of time, I'll ask Dr. Mupeta to sum it up.
Okay, thank you very much. And I think most of us have been able to bring and highlight most of this patient. What we have to realize with regards to question number one about issues of changing treatment from first line to second. Now, we already know that this actually client stopped taking the drugs, isn't it? Despite him going to the clinic, he was just going to pack the drugs at home. So what this patient would need, even if EAC was done in one day, he was still packing. This patient would need adherence counseling, and remember adherence with possible docs. This is where you actually now get even treatment support. Could be a relative or even community workers, health workers, who can actually monitor that this patient is actually, taking the drugs every day. Remember, treatment failure as the surname, as Dr. Sevilla always says. So we always have to ensure that adherence is there. So you can only say this patient failed treatment if somebody has been on ART and then all the immunovirological and clinical parameters falling apart. This patient, there was clear indication treatment was failing treatment, but it was purely due to poor adherence. So I would not recommend a switch at this particular point. And the fact that he has opportunistic infections, don't need to change any area. We need to continue because of presence of 2. Okay, sorry that we were muted. The last question, which is Indian Inc., and I think it has already been said. Indian Inc. has got a high sensitivity of about 86% for diagnosis of cryptococcal meningitis, but it should not be used for monitoring of treatment because it's highly unreliable. It can still be positive even when the cryptococcus, the fungi, is dead, because all it shows is that there's a fungus. Whether alive or dead, we need a culture which is actually needed to be done. Now, there are other tests that you can do to monitor treatment in cryptococcus, and one of them is beta-D glucan levels from CSF. So there's a high correlation between treatment response and BDG decline in CSF. But otherwise, Indian Inc., it cannot be used and should not be used for treatment.
Okay, have we gotten those recommendations? If you are able to hear us, please show us, give us a signal. Are you able to hear us? Okay, thank you, thank you. Do we have any concerns or any clarifications before we can go back to the main group? Yes, Monze Mission?
Yes, clarification. This patient has got a BMI of 13 point something. I think we need to pay attention as well to the TDF that this patient is taking. We need to do the creatinine and check if it's okay. And then if it's not fine, we can remove the TDF and substitute with ABC.
Okay, thank you very much.
Clearance is 52.1. Clearance is 52.1.
So the weight is 43.7, creatinine clearance is 52.1.
So what can we say about that, Doc, about TDF? Is it contraindicated? No. So this patient will actually be well on TLE, which the patient has already been. What we don't need to do is change to TLD because we don't know if this patient is going to.
Hello. 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 You're not getting it. Are you getting it?
Okay.
Yeah, so we are quickly going back. So issues of nutrition, putting back this patient on ART. If the patient had completely stopped, then we have to have a lead time for us to start. But if the patient did not completely stop, then we should continue the ART alongside the treatment for meningitis. We recommend that we have to find a way of looking for the patient, which is quite important. And the ink should not be used for monitoring of success.
Okay, thank you so much. Thank you for your participation. We shall return to the main session at this point.
Okay, welcome back. We shall quickly go into the summaries from the recommendations from the different breakout groups. Can we have group 2 to give us your recommendations?
Hi, Zico. Am I group 2? Cozy as room?
Yes. Yes,
okay.
you can go ahead.
So I'll go ahead and give the thoughts of the different parts of the group, not necessarily the consensus. So there was a school of thought that said that we should not switch because the patient is showing signs of non-adherence. We should first do enhanced adherence counseling and keep him on this same regime. Then there was a school of thought that said we should change him immediately as we are waiting for the genotype. I will not give my thoughts for that advice, but some people thought we should just change to AZT3 for Piniva now as we are waiting. While most people felt we need to wait, we continue the TLE because they felt he was non-adherent. As for the TB, the response was no. Now that we have access to tests like the urine lamp, this would be a good candidate for a urine lamp. We should test that and see if that's positive. Also, besides that, we know that crypto may present with some signs and symptoms that are very similar to TB. So that was the response there. As for India Inc., the response was that yes, it's reliable. You can do it at 7 days and at 14 days, and you see that. Of course, we know that crypto, you can see it. Even if the crypto is dead, you will see it, and it will show you that this crypto is the person still has crypto, even after they are cured. So at some point, it actually becomes unreliable because they do die.
Okay, thank you so much, Dr. Foloshi. Can we have someone from group 3?
Yes, good afternoon, team. So for group 3, we, of course, like Dr. Foloshi had said, had 2 schools of thought, but one, we guess, prevailed. The first one was no need to switch because of the history of poor adherence, but I think at the end of the day, we know that this patient is very sick with that severe immunosuppression. So we would rather start the adherence counseling right now while we put this patient on crypto treatment. Then after about 8 to 10 weeks of treatment of crypto, we may need to switch to the effective therapy, and in this case, it being we are going to lose this patient. And then concerning TB treatment, very reluctant because the above symptoms can actually be pointing to crypto, and we've got an organism that we have to deal with in this particular case. So there may be no need to treat the TB. And then for the third question, yes, it is reliable. Okay, as Sombo has said, done at day 7, day 14. If there's no clearance, we may need to do culture in this particular case, but otherwise, India Inc. is reliable. Thank you.
Thank you, Davis, for that. Finally, we shall ask Dr. Mupeta to sum up the recommendations from our team and also give his expert advice before we wrap up the case.
Okay, so thank you very much. Some of the issues which have been discussed from the other groups are very similar. So I'll address the first question, which is a strong history of poor adherence and switching of ART. So from what we've been given in this case is that the brother found that he was not taking. He would go and collect the drugs from the clinic and was not taking. So the information given is showing that this patient actually stopped the treatment rather than one who would take and skip the drugs. So I would actually think of not switching this patient, but starting on the same regimen as most people are practice. Stop actually can suppress on the initial regimen as we have discussed in previous sessions. So the first thing that we need to address in this patient, like it has been said, is adherence. So this patient, we know he was going to the clinic, but actually the problem was taking. So this is where now we need a treatment supporter because he has the drugs at home. All he needed is somebody to assist him take those drugs. We need a treatment supporter. In this case, I would recommend that the brother who seems to be concerned that he was able to travel to go and bring him back to or the mother now, because we've been told that when staying with the mother, things are a bit better. The fact that he in a family is stable, I think it's something that can improve. If not, I think it's incumbent upon the health center to find some community lay health workers who are going to actually assist with thoughts, direct therapy in this patient so that we can improve adherence, and then counseling should definitely be ongoing. This patient is also severely malnourished. BMI is very low, so we need to actually ensure that we fortify the nutrition aspect in this patient so that we can also avoid the other side effects that may come with introduction of other drugs. So basically, this is what I would say. I think it would not be appropriate at this time to change, but we know that he's got a high viral load. It would be important and that we do a genotype as well, that when the knows that this is unsensitive, there's a likelihood that this patient definitely will. especially that the chest X-ray is not suggestive. So we would actually recommend a urine lamp in this patient. If at all urine lamp is unavailable at Sesheke, I think we should also advocate for transportation of the sample to the nearest facility that can do either an expert or a urine lamp in this patient. Livingston stands to be, quite proximate to Sesheke. Number 3, Indian ink monitoring treatment. In patients with severe immunosuppression and very high load titers, it might not be the case, as most of them, they actually fail to clear. So Indian ink at best actually may not be the best tool to monitor treatment success. As it has been said, even dead fungi can actually show that they are present on India ink, and therefore would actually, produce confusion in treating clinicians. There are other ways of monitoring treatment response in cryptococcal. The recommended one definitely is a fungal culture, which should be done anything after day 10 or 14, somewhere there. And then if you are unable to have access to a fungal culture, other ones which are a little bit fancy for some of our facilities can actually include CSF beta-D-glucan, which actually correlates very well with treatment response in cryptococcal meningitis. Other ones for advanced centers, which they can do, is interferon gamma, which also shows a correlation with treatment success. The interpretation of positive India ink in a patient 14 days post-treatment should actually be done cautiously and can be misleading. But if you happen to find that it has cleared, mainly it can be a little bit helpful, but I would give a caution, especially for lower levels, who might find it very confusing when it's positive, which is likely going to happen in a patient who is likely going to have a very high load of fungi and severely immunosuppressed like this one.
Thank you very much, Dr. Mupeta. I'll just give quickly a summary of the recommendations. That firstly, for the first question, we need to improve on adherence. To improve his adherence, like he said, it's adherence, adherence, adherence. And if after sustained adherence, he's still virologically unsuppressed, then we can make a move to switch to second line. But at this point, to maintain him on the same regimen, and there's actually a chance of him suppressing on the same regimen. And furthermore, at this time that he's being treated for OIs, particularly crypto meningitis, we cannot switch to another line because of fears of iris, which can actually increase his mortality. Next is we also need to do genotype if he remains unsuppressed on sustained adherence counseling. And we also need to screen for TB. If we do not have expert at our facility, we can send to the nearest facility. In this case, Livingston has been suggested. And we can also make use of urine lamp when available. Then Indian ink should not be used. Indian ink should not be used as a monitoring tool because it is not the best of tools. But
Dr. Zico. Hi, Dr. Zico.
I think they've lost internet. Essentially, what he was saying is that you can use India ink as a monitoring tool with limited use, meaning for some time it will show you clearing, but at some point it becomes pretty useless because sometimes you may see this dead crypto, which will give you a false sense that you have not cleared it. So as you said, the best way of monitoring is actually a CSF culture. And the longer you go in the treatment, the longer you should let the lab culture the CSF. So the standard culture is 3 days. Then you can, we tend to lengthen it to 5 days if we are suspicious or if we are seeing some dead crypto.
Okay, thank you, Dr. Foloshi. We are back. We apologize for the intermittent loss in network, but the summary has been given, and we hope Yeta you have gotten the. We hope Yeta you have gotten the recommendations. So we will ask if you are. What is your feedback based on the recommendations that have been given? Yeta, are we there?
So as we wait for Yeta to be online, Dr. Sivile has something to say.
Okay.
Dr. Can you get me?
Yes, we can.
Yeah, I think so. Again, has to do with the recommendations. This patient has got a CD4 count which is unrecordable, 0. I still think it's not the correct path to take him on the same drugs, even when after 8 weeks he was on TRE. Why don't we give him TLD? Then we are somehow at middle ground, because we don't know. The history of not taking the drugs always unreliable, as you may know. We can't do genotype and so on. Since the thought is, if we re-challenge the same drugs, maybe they might work. But why not give him that something that we are sure that will work? Recommend that the patient is restarted on TLD as opposed to TRE. That would be my thought. And I still agree with Dr. Foloshi, what she was saying. I think to some extent you can still use the India ink, especially that most of the iris you see against crypto is actually it's against antigens, dead antigens, as opposed to the living, the fungus that is alive. So there's value in seeing that there's fungal clearance, which is the first aim of treatment. Of course, like people have said, once the clearance is not there, you need the culture, or there might be dead things and things like that. But I think there's still that value. That was my contribution. I don't know your response to those.
And maybe just to add on the issue of genotype, I mean, looking at what we have said, if at all we take it that this patient was not taking the medication, it will not be wise for us to recommend the genotype until at least after some time when you know that the patient has been taking the drugs. And then we do a viral load, and if it's too high, then we do a genotype and switch to the regimen that the genotype will tell us. Thank you.
Okay, so I'll start with the one with Indian ink. Not Indian, but India ink. First of all, I think you have to follow me. One, we are looking at a very broad network, and then looking at this, like I said, as people, a positive Indian ink for 2 days after treatment with effective therapy. So I would not recommend, based on the fact that it would be very difficult for some people to interpret a positive Indian ink at 15 days. Suffice to say, I know that probably Dr. Sivile, you and anybody else working in infectious disease, would be very easy for you to chart the way forward. But looking at the wider network might not be the case. Secondly, this patient is severely ill, and actually we haven't been given. It's one who I expect that probably has got a very high fungal load, and even clearance at day 7 or 14. In this patient, I expect that will be very slow. And if we use the India ink, it will actually be very confusing. And the best, like we have seen, which we also know, is culture. And then there are others probably which might not be attainable at levels like in theater, which is big. But those definitely are way more reliable than repeating an Indian thing in this. I, for one, would not recommend, especially if you're not capable of interpreting what a positive, India ink is at day 14. But if you are one who is able to, that should be able to differentiate that if there is any clinical improvement, and that would definitely not impact your decision whether to continue or not to continue with the insertion, then well and good, it's something that you can. But I would not routinely encourage people to do that because it will produce very misleading, results for the majority who cannot know this. With regards to this patient, there are several issues in this one. Yes, any history that is taken is unreliable. But I think what would be very reliable is to know how many bottles did they find in this patient. So if we find that probably you would open, maybe just take one or not, or you take half. So it will depend on what we are finding in this bottle, like we have seen. But even then, switching this patient to TLD, effectively say, even if tenofovir had actually resist, effectively this patient is going to suppress because of the disease. And now, suppression in this patient and the risk of at the period this patient has stayed without treatment, I anticipate a lot of problems with regards to iris in this patient. You are right to point that the CD4 was actually, the machine failed to pick. And in most instances, when you get star, it means the CD4 is actually very, very low. I expect this patient that is likely going to develop iris sooner or later. And changing to TLD probably might bring in a little. But I would recommend that we restart with the drug that the patient has been, and if this patient suppresses on TLD, I would actually recommend that we switch to TLD rather than switching from the beginning. That basically would be my reason why I would.
Okay, thank you so much. And lastly, on the genotyping, the recommendation wasn't to genotype him now, but after enhanced adherence counseling and assurance that he's been taking the drugs, and then with sustained a high viral load, that's when we would do the genotype, and not at this particular moment. We have actually run out of time, but before we do say farewell, would need to get feedback from Yeta if they are comfortable with the recommendations that have been given. Yeta, are we there?
Dr. Zico.
Yes.
Honestly, we got some parts. I think the last part, but I think we'll just wait for the recommendations that will be shared, because some things we weren't really able to get.
Okay.
I think we just had to speak at the end.
Dr. Mupeta, last.
All right, just a concern, I think, and it's on a light note. Please, when we join ECHO, let's try to observe the etiquette and especially the background. We can see some people are in cars. It's looking like one of those Tier 1 videos.
Okay, thank you so much. We are grateful for your participation, and we also do apologize for the break in internet connectivity from our end. We hope that this, regardless of that, you were still able to pick the main points of the discussion. So from us here, we are saying goodbye. We shall meet next week on Monday. Thank you so much.
Thank you.